Secretary Francine Laksamana. We are also inviting former Secretary Janet Garin, Ms. Teresa Martinez of PHAP, and Assistant Secretary Carlos Bernardo Abad Santos of the National Economic Development Authority to join us in the open forum. This open forum session will be moderated by a clinical associate professor of the Department welcome Dr. Maria Dominga B. Padilla. Joining Dr. Padilla is the head of the Zuilig School of Development Management. He was formerly Undersecretary at the Philippine Department of Health, and his portfolio covered health regulations, health and trade, private-public partnerships, supply chain management, and innovations. Let us call on Dr. Kenneth Hartigan-Go.
Hello, good morning everybody, ladies and gentlemen. Mingita and I will be facilitating this session. We're very excited with wonderful speakers in this panel this morning. We've learned a lot about whole of systems approach, and we said, having knowledge, we should translate this to action. What do you think, Mingita?
Well, definitely. I'll just use it. You know, we were here last year, and the main difference now is that they said there's a call to action. And while we were outside, a professor from UP came to me and said, "This is my first time to attend this." She was so excited. Is there a way to measure how successful it will be? Is there a metric by which we can measure whether it's all just platitudes or whether it can really be translated into action? Good question. That's a challenge for the organizers. So now, I don't want to talk so much, Ken. But before we start, can we just congratulate Ken? He was just elected the new president of the Philippine College of Physicians. And I look forward, I hope that this will mean a new era wherein you have very relevant partnerships with government and with other organizations. Yeah.
Thank you, Mingita. With all your advice and support, maybe we have a stand a good chance. But Mingita, before we proceed, there are a lot of wonderful people in the audience. I can't name all of them, but there are two people I want to acknowledge, if I
Yes,
may, and
sure.
they are our teachers.
Oh, yeah, okay. Please,
Dr.
please.
Ernie,
We were classmates, by the way. So, no.
Classmates in
school.
med school.
Never mind
Never
when.
mind class. I'd like to acknowledge Dr. Ernie Domingo and my professor in internal medicine.
Our
and
professor
Our
in
professor,
internal
yes.
medicine.
And Dr. Esperanza Cabral.
Our professor also in
Pharmacology.
one of the terrors after, actually. We were always afraid of our exams.
Always acknowledge our teachers.
Okay, yes.
Okay.
Okay. So I think without further ado, I have questions, but we'd like to first open the floor for your questions. And there are microphones in the room for those who wish to ask some questions. Please don't be shy. Anyone?
Yes, please.
Yeah.
Please introduce yourself and then proceed with your question or comments. Thank you.
Here. we have-
We'll try another one.
This one works. Thank you. Thank you. My name's Gabriel Georgie. I'm the president of Takeda Healthcare in the Philippines. Got a question for Mr. Santos. So you presented some wonderful initiatives and I wonder how we're going to achieve them all. But one thing that really stuck out for me was the decline in the fertility rate, the ambition. So I actually went online and I looked at the fertility rates of all the countries in the world. There's 223 and they range from 6.89 in Niger all the way down to Singapore, which is 0.8. And so the Philippines was right in the middle at about 3.03. So my question is, how do we aim to reduce the fertility rate? How do we reach the people? Because we know the majority of the births are occurring amongst the poorer population, so less education, less access to knowledge. So how do we reach these people to educate to reduce the fertility rate?
Well, the major policy would be the RPRH, Responsible Parenthood and Reproductive Health Law, and that's a major piece of legislation that everybody worked on for the years. Uh, and that was supposed to support lowering the fertility rate. However, right now there are road bumps and major obstacles to fully implementing the RPRH. So that is something that we have to work on and hopefully wait and hopefully get a favorable decision from the Supreme Court. Beyond that, there are initiatives in DOH and PAPCOM and the ALG with regards to addressing fertility and looking at family planning and management. And hopefully, we can follow through on that, and eventually, we'll be able to overcome the huge obstacles, the huge legal obstacles, to moving forward with responsible parenthood and reproductive health. So we're at a crossroads right now, and I think everybody is waiting. But I guess DOH might also have some inputs on.
Yeah, Francine, no? And then maybe after that, maybe Secretary Jeanette might also want to say something. No, no more. Sila na. Okay. Si ASEC Francine Laksamana.
Yeah, good morning to everyone. Actually, right now, we are working on the implementing rules and regulations from the Executive Order number 12, which was signed by the President last January 2017. And the Department of Health has already signed also the administrative order for the implementing rules and regulations. And right now, our plan is really starting this month. We have already conducted a lot of workshops with our regional directors, with our provincial health officers, including the NGO, civil society organizations, so that we can bring down this executive order, and hopefully we can really put our goals on our desired family size, achieving the desired family size and zero unmet need for family planning in the near 2020. So this is our directions right now.
Yeah, I didn't want to add on, but with due courtesy to, of course, the office that I belonged before, let me put it this way, as the principal author of the reproductive health law. No office can solve this problem unless the Supreme Court lifts its TRO. Whether we do 1,000 or even 1,000,000 seminars or workshops, it would be nothing. Why? Because the TRO covers two things. Not only the implementation, and not only the family planning implant or the implanon, but the killer TRO that's incorporated in that is the prohibition of registration and even renewal of licenses. What does this mean? Ang ibig po sabihin nito, hindi pwedeng erehistro ulit. Kung ikaw ay bagong commodity, you cannot be given a license or a certificate of product registration. But if you are already registered, which we give a permit between 3 to 5 years, when that TRO was given, I think that was in 2014, many of the commodities were already about to expire. And that was why our push, together with Secretary Cabral and Congressman Lagman at the time, was just to comply and not to file a motion for reconsideration, because filing an MR will in effect let it sleep for a long time or maybe forever. So if we are talking about achieving the total fertility rate or the desired family size or giving an informed choice, there is only one solution, and the solution lies before the Supreme Court now that an MR has already been filed. Thank you.
I have a follow-up question. Couldn't we simply comply with the requirements of the Supreme Court and hold a public hearing, just one public hearing to end the impasse?
Yeah, actually, that's
Tapos na, so,
the recent
What's
update.
gonna happen?
FDA will comply.
Okay.
And in terms of the TRO, we are coming up with the 1 million signatures from all over the sectors, from all other stakeholders for the lifting of the TRO. So concomitant to that, FDA has already committed to
finally,
comply
because
so that public hearings can be done. So
One last,
to-
this is very important, because I heard it's tapos na, meaning they should have done that within 15 days, or what was the, but you can still do that, right?
Yeah,
It will
we
still
can.
be, and if you do it,
Yeah,
the
we were
Supreme
given an
Court-
extension.
Okay, that's,
the
I
Supreme
think
Court.
it's about time we just comply, you know?
Yes, that's true.
Conduct a public hearing, resolve it, yeah.
We have a gentleman who's going to ask a question. Please, you can line up into the
Yeah,
aisle so
good-
it's easier. Please.
Yes.
Tell us who you are, comments, questions, please. Does it work?
Hello. Hi. Can you hear me?
Yeah, we hear you.
So, hi, I'm Chris Herrera from Merck. I don't think the
Same
fa-
subject, wait.
Yeah.
Can we take one more comment on the same subject?
Yes,
Well,
of
one
course,
more,
yes.
one last comment, yes.
We'll just allow him just
One
on,
last,
on this
yeah.
topic.
And of course, as a population gets richer, the population goes down. They have more things to do. Isn't it? Yeah.
I'm at a loss as to why we need to have public hearings and to understand what the hell the Supreme Court is doing. This is a medical issue. The public doesn't know whether these whether these drugs are abortifacients or not. It's not our expertise. It is the expertise of medical experts who worldwide have said these are not abortifacients. So why is the Supreme Court even accepting this case? Why doesn't it just tell the people who have filed this case that this is a medical issue, not relevant to the courts, and not allowed? I don't think we are pushing this hard enough to get the Supreme Court to get out of this, because the Supreme Court has no role
Well,
in this.
noted. Thank you for that comment. And Mr. Wallace, I don't think it's just in this issue, but there are many issues that people always debate about. However, it is there, and I think, and can I?
Thank you for that,
Yeah.
Peter. Actually,
Yeah.
Mr. Peter Wallace was an advocate who was there before I was there, and when I joined Congress and pushed for this law, I was thinking that it might be passed, not at my time. But of course, with their support, it was some kind of a graduation gift when I ended my term in Congress. Going back to the question, yes, that was a question that is prodding our minds for several years. And the 1 year I had with DOH taught me to realize one thing. There are just obstacles that we don't agree with, but we have to live with it. So rather than fighting and insisting and telling the Supreme Court that we will be pushing for a motion for reconsideration because we don't believe in what you say, I would look at it the other way around. Our ultimate objective and goal is to deliver for our people. And if we say delivering for our people, that simply means just complying with a public hearing. Anyway, the good Director General of FDA has said that within 1 month or 2 months' time last year, she could have done it before the end of the year. Once she has complied with it, it's in her ball. She decides, and then we submit to the Supreme Court, and we now push through with delivery, because that is what NEDA has in their minds.
Thank you. Mindful of the limited time we have 3 gentlemen on the line who wants to ask question. You go ahead. We'll take the 3 of you questions, and then we'll give it to the panelists. Go ahead, sir.
Hi, I'm Chris Herrera from Merck. So, universal healthcare as a concept isn't anything new. I think it was first articulated in 1999 under Doc Quasi's health sector reform agenda to the Formula One of Secretary Dairit, and then we had KP under ICONA, as well as now the Philippine Health Agenda. What's disturbing was, even though we have a lot of gains since 1999, we now have DOH budget at around 90 billion from around 10 billion in 2000. We actually have PhilHealth being covered by the national government, and so many things then. But in spite of all these advancements, out-of-pocket expenditures have not moved. They've actually increased from 1999 to 2016. And in 2011, they did a system of health accounts. This was published by Dr. Racelis and Dr. Lilibeth David. And they looked at these aggregated out-of-pocket expenditures. And the biggest driver of costs was actually outpatient medications, which PhilHealth does not support. And there are attempts to really try to regulate that. But in terms of providing a sustainable access to medications, I think that there has not been a social safety net from the DOH or from PhilHealth. Now, my question to ASEC Abad Santos, as well as to the department, ASEC Laksamana and ASEC Tayag, is, do we see the Philippine Health Agenda being the first one to disrupt this pattern and finally create a sustainable framework of a social safety net for outpatient medications?
Okay, before you answer, we'll take the second question and a third one, and then we can go ahead.
Okay.
Gentlemen on my right, please.
So you remember that.
Hello, good morning. I'd like to thank the panelists. It was a wonderful session this morning. My question is related to the governance model for health system delivery. We discussed about Philippine Health Agenda. I'm a municipal mayor of a municipality and the Philippine Development Agenda. But one thing we are certain that will happen within this year is the shift in government structure from our current government structure to federal, which I think is being pushed by almost everyone already. And how I think probably by next year, we'll be seeing this shift already in terms of the different regional states, or I don't know how they will be framing it, but the federal setup will definitely affect both the Philippine Development Agenda and most especially the Philippine Health Agenda.
Mr. Da Silva, sorry, go ahead.
Department of Health will be having? Because what I heard from Secretary Dominguez was the tax reforms will put more money on health care. However, it's focused on infrastructure, both personnel and physical facilities. However, we also know that, as former Secretary Garin said, out of pocket is around 57%. So how does DOH plan to balance this out? Is there a specific target on out-of-pocket expense? At what level do you think it would be more ideal, so much so that you can say that the financial burden on the Filipinos have been lessened significantly?
Ma'am, we'll first answer the questions and we'll get back to you. First question for ASEC Laksamana.
Actually, the question from the first gentleman regarding the out-of-pocket and also from the Roche representative. We are trying, the Department of Health, remember in the Philippine Health Agenda, we have the 3 guarantees. And the first guarantee is on the triple burden of diseases and the life stage approaches. In that portion, we have already the primary health care packages. We have already an administrative order for that, so that all the 20 million Filipinos, initially for the poorest of the poor, it will be covered that 100%, no out-of-pocket expenses will be given to these 20 million Filipinos. And the second one are the informal sectors like the fishermen, the farmers. We're working on that they will also be included together with the 20 million. And we're working it out with PhilHealth. And in terms of decreasing the out-of-pocket, as Secretary Garina said, it's already 60%, still in the 60% out-of-pocket. The bigger portion of the out-of-pocket is really in the private sector, especially in our curative care in the hospitals. And that's what we are also working on with PhilHealth in terms of putting the out-of-pocket expenses from 60 to 50 and then to around 30 to 40. And it will really entail a lot of hard work, and it will not be done on an overnight basis. It will really take time. And if we are talking about health sector reform agenda from the health sector reform has already transcends from different kinds of reform. And if we look at the presentation a while ago of Dr. Lin regarding the health systems approach, it's not only in the service delivery part that we have to look at. We have to look at the different kinds of agents there, the service delivery, the governance, health financing. We have to look at all these three different aspects of the entire healthcare delivery system. So we cannot do that overnight. But in terms of the Philippine Health Agenda, we are trying to address all the out-of-pocket expenses to decrease it to less than 50%, and then to cover all the Filipinos. If we want universal health care, it should include all the Filipinos that out-of-pocket expenses will not be experienced. In the presentation a while ago, we have seen there that the goal of universal health care is for all people should have quality health services with no financial hardship. So that is also the goal of the Philippines in the Philippine Health Agenda and in also in consistent with the Philippine Development Plan. So that's a preparation. And answering to all the other questions, in the 3 guarantees, we have the first guarantee, as I have mentioned, the triple burden of diseases and the life stage approach. The second guarantee is on the service delivery network. We're looking at different levels from the primary up to the tertiary level and our specialty hospitals. All our primary care patients will be referred to these different levels in the service delivery network, and no poor patient will have an out-of-pocket because it will be the service delivery network who will navigate these patients to the appropriate curative care. And PhilHealth will be the one to take care of their health costs. And our third guarantee is really achievement of the universal health care coverage. So that's how we will look at it in the universal health care.
Thank you and good morning, everyone. Our response to the out-of-pocket expenses is based on the Pareto principle. An analysis of the out-of-pocket expenses point to the significant contribution of medicines. And when you need medicines, that means you are sick. And so therefore, if you're not sick, most likely you will not need these medicines, whether they're costly, because cost is relative. And so therefore, there is going to be a shift in the health system in terms of prioritizing primary health care, that's prevention. There is now a huge effort by the Department of Health and all our partners to focus on the gatekeeping mechanism, the first contact principle at the lowest level of health care, that everyone is seen at least 2 times a year, and we did that, and that we are going to evaluate their health status, their risk, and prevent illnesses. So that's the game plan. That's the broad game plan. Now, we are also going to use instruments for medicines for preventing them to be sky high. So we are looking at the maximum drug retail price, which is anathema to our industry partners, but this is in the law. We're looking at the advantages of looking at the details of the Cheaper Medicines Act, and those that actually accrue our senior citizens when they get discounts. But altogether, the root cause should be addressed. And so therefore, it's very important that more people are healthy rather than more people being sick.
May I make one comment? No? Actually, there's the universal health care bill. Because under the present setup, no matter how good your plans, PhilHealth cannot pay. It's going to be run to the ground if we don't change the system. So all these good, beautiful plans, no? There's a universal health care bill now. There's a matrix. And I think even DOH has great plans. It's the money also that needs, who pays for what. PhilHealth can only pay so much. Even for no balance billing, it runs some hospitals to the ground, especially if you're not a government hospital. LGUs get affected. So I think the UHC bill now is a very good bill. At least the matrix, if they can come up with a very good bill, then they're also talking about pooled procurement of medicines that can also help. So my point is, our poor DOH is working under a system wherein it's really impossible to totally bring down all the costs, all the out-of-pocket, despite all.
Can I comment on that?
Sure, sure.
Can I encapsulate everything
Yes.
to this word, pharma, P-H-A-R-M, M-A? Anyway, we are here for that reason, for a forum. P is to protecting our gains. We have so much gains in the past several years, but we have to protect them because we can slide anytime. For example, for our vaccine coverage, there's a slide, and so therefore we have to protect our gains. In family planning, we have to protect our gains, and the challenge is by the Supreme Court. Then H is to harness alliance. The reason we're here, because we need you. That's the first part of our All for Health towards Health for All. Then A is aligning our goals. We cannot be silos. You're pursuing another vision and we're pursuing another vision. That's why there is an ambition not in 2040. And then we have R. And what is R? Returning the investments, valuing it. The values for patients and clients is not costs or outcomes. It is rather their experience, and it has been elucidated. M is to mitigate the impact, and A is to act as if the future is here. We're encapsulating that, and we hope that you will stay for the rest of the day because we're going to provide you more details in the coming sessions. Thank you.
Okay, thank you.
We have no more.
Maybe-
Sorry,
maybe-
we'll have to move on. I'm terribly sorry. Asek Abad Santos, the good mayor asked a question about federalism in healthcare. Would you venture a forecast?
Well, first thing is that there's talk of federalism all over the place, and it's really because it's when you talk of federalism, it's a continuum. It's a lot of things. There are a lot of permutations, and the problem in terms of evidence, whether it's going to be good or bad, is that we need to first define what type of federalism and how it's going to be done. And we hope that the debates progress, and there will be consensus probably in terms of what type of federalism, or 3 types or whatever, so that then you can bring in the evidence. So right now, what you can say is that it can be good, it can be bad, given the different experiences of other countries, but you really cannot put in robust evidence in saying whether or not it's going to be good or bad, or what the impact is, because you don't have a clear model that
We need
you're
more
pushing.
study. Yep.
Yes, and I think more debates.
Thank you very much, Asek. Ma'am, go ahead.
We asked for an extension. Yeah.
Good morning. I'm Liza Martinez from the Philippine Alliance of Persons with Chronic Illness, and we have colleagues from the UN Convention on the Rights of Persons with Disabilities Coalition. Since we're positioning healthcare in the context of social development, national financing, and so on, we are noticing a very glaring absence of disability-related costs, which comprise a significant portion of the population. WHO estimates 10 to 15% of any given population are affected by disability. In the pipeline, we have legislation which is proposing to look at drug dependency as a mental health issue and a psychosocial disability. We have cross-cutting concerns for children, etc., older persons, and so on. But there is nothing in the talks that I heard this morning which even touch on a nationally determined social protection floor, which looks comprehensively at the issue of healthcare in the context of education and especially of poverty. Disability-related costs are overlooked, unfortunately, by cross-agencies for at least 35 years since Republic Act 7277, or the Magna Carta of Persons with Disabilities. We appreciate innovative attempts by PhilHealth to have Z packages, for instance, for prosthesis, for child cancers, chronic renal disease, breast cancer, and so on. But the whole population and sector of persons with disabilities is extremely diverse. And disability-related costs, which include medications, assistive devices and technology, and etc., affect individuals as well as families and households who have members with disabilities. This is sorely absent in all of our conversations. And I would like to hear some of the comments of our Assistant Secretary from NEDA, since this is really a development concern. Thank you very much.
We'll take one more question, and this has to be the last. And I'm sorry, please go ahead, and then we'll answer this.
There's still a session this afternoon, and then maybe over lunch you can network and ask them questions. Unfortunately, we're pressed for time.
Let's keep it.
Good morning. I'm Salve Basiano of the National Anti-Poverty Commission Senior Counsel. My question is about, um, availment of services, of goods are subsidized mostly by government, but within the context of hospitalization. After the treatment, the patient is discharged, and his family takes on full responsibility on the cost and expense of rehabilitation and uh, um, continuation of treatment. So my question is, does the DOH have started or even initiated formulation of any such program for outpatients? Thank you.
On the first part of the question in terms of the social protection floor, when you look at Chapter 11 of the plan, it looks at establishing a social protection floor and legislating that. So I think that's one initiative. But basically, for disabilities, I guess that they might need to look into more, looking at specific requirements of that sector, because I mean that's a specialized sector. There might be more need for special care and additional resources. But I think we'll have to look at that further.
Regarding that persons with disability, actually in the Department of Health, initially we have already started our sight prevention and hearing impairment program, wherein we have involved already other private sectors. Just recently, we had strategic planning with ENT practitioners, and we're putting up some strategies like regular stakeholders meeting, because the Department of Health has already donated eyeglasses for patients with poor vision. And the next step now is putting up the hearing center at the East Avenue. But in terms of the program, we have developed specific programs in the RHU in terms of detecting vision and hearing impairments. We have already started providing assistance to our health facilities, like putting up the geometers and other devices so that we can prevent the hearing and visual impairment for our children. And with regards the children's protection in terms of disability, we had already put that as part of the agenda in the Council for the Welfare of Children. And it is already one of the focus of the SWD and the Department of Health to put that as part of the agenda. And with regards to the Department of Education, we have developed a module with the Natasha Goldborn Foundation regarding the Emotional Resiliency Program, together with the Comprehensive Sexuality Education with the Department of Health. So this is moving forward, all this identification of future disabilities, early pregnancies, so these are all in the prevention aspects. And the other question on the
Continuity of care from outpatient
continuity
to
of
rehabilitation.
if the patient who has been discharged from the hospital has been identified as among the poorest of the poor or in the informal sector, we will be evaluating the patient if there's a continuum of care from the prevention and control, the curative care, and we have already also established in the Department of Health our Medicine Access Program, that all patients, especially cancer patients, have been discharged from the hospital. We have this specific office in the Department of Health, the Medicine Access Program, where we give the full course of the treatment to the patient for as long as they are endorsed by the hospital that they were treated for these cases. So we have patients who have availed of all these services from the Department of Health, and it started in the last quarter of 2016.
Thank you very much, Asek. I believe from the persons of disability, with disability, they're asking for a comprehensive policy that links a whole of government and systems approach. I would recommend an offline discussion after
Yes,
this.
yes.
during
We
lunch.
are working on that administrative order
Yes,
that
thank
will
you.
trickle down up to the level of the local
Thank you very
government.
much.
I think we have to close the open forum for now because lunch is going to be served. But we'd like to thank all the panelists and all those who participated. There's so many questions, even we have questions, but perhaps we can discuss them later.